second sessions of Good evening and welcome to our second session of webinars hosted by Vision Care Association in collaboration with the Eastern Mediterranean Council of Optometry. I'm thrilled to welcome you to our fourth webinar in this session entitled In Binocular Vision, Single Vision Essentials in Optometry Practice. I'm Kauthar, your host for today, and I would like to welcome Dr. Fahima Karolia. She is an orthoptist with over than 11 years of experience in clinical care, graduated from the University of Sheffield in London, worked at Moorfields hospitals in London and UAE, dedicated to clinical care at Sheikh Khalifa Medical City Hospital, a flagship tertiary in hospitals in the UAE, and a large teaching medical center in Abu Dhabi. During the session, please make sure your microphones and cams are off. If you have any question, keep it at the end of the session in the Q&A box, and we'll get to them back shortly. Dr. Fahima, please, you can proceed with your lecture. Thank you.
Hello, thank you very much for that introduction, Kauthar. Thank you to Amir and Maya for inviting me at the Vision Care Association and the team. I'm so excited to do this webinar with you guys. I know binocular single vision is not always the most exciting for optometrists and the ophthalmologists as well. But I'm going to try and really simplify it for you guys so you really understand it, you really get the logistics behind it, and you really hopefully enjoy it and want to use it into your practice. So I'm going to go through today all the different types of binocular single vision, different types of squints, and a very easy assessment, what you guys should be doing. Of course, if you have any questions, keep them. If I've not answered them by the end of the session, then do ask them, and I'll be happy to answer them for you. So a little bit about myself. My name's Fahima. I'm an orthoptist living in Abu Dhabi, working at the Sheikh Khalifa Medical City Hospital. I have two young kids, one 5-year-old, one 1-year-old, both asleep right now, which is lovely because I have some peace to do this. And I'm very passionate about orthoptics and promoting orthoptics, but also collaborating, working closely in a team, working in a multidisciplinary team, working closely with optometrists, working closely with ophthalmic technicians, and also the ophthalmologists. I think it's really important. I think it's really important to understand what we all do and how we can all each add value to each other. So again, I'm very happy to be invited today. Just to disclose, I have no financial interest or relation with any of the products mentioned, any of the tests that I mentioned in my talk today. So the main objectives of today is to revisit the importance and aims of a good binocular vision assessment, to learn how to accurately test for latent or constant squints, ocular motility, and stereopsis. And by the end of this session, I really want to enable you as optometrists to confidently select and carry out appropriate BV tests. I really hope we'll be able to get that far. So keep that in mind whilst I'm talking, and any questions you have, make sure you jot them down, okay? So firstly, what is binocular single vision? Well, it's in the name, isn't it? We want to use two eyes, but we want to see one image. Nice and easy. How do we do that? Because our eyes are not in the same position. One eye's here, one eye's here. Now, we call binocular single vision the ability to use both eyes simultaneously so that each eye contributes to a common single perception. Normal binocular single vision occurs with bifoveal fixation and normal retinal correspondence in everyday sight. So we've got this lovely little diagram over here. So we have just say the left eye over here, the right eye over here, an object over here. Now we've got foveal fixation in the left eye, foveal fixation in the right eye. And then here we have what we call a third eye. This is our binocular single vision. So this is our perceived image because our left eye is here, our right eye is here. This is our third eye that sits right in the middle. Okay. So obviously the fovea projects straight ahead and corresponds to the fovea of the other eye. So you've got your fovea left eye, fovea right eye. The nasal and temporal retina. So the nasal retina projects temporally and the temporal retina projects nasally. We know that. This is simple. Now, one thing that's really important for us when we're thinking of binocular single vision in clinic, and we're thinking of how do we go about tackling our assessment of binocular single vision. We have a patient. Now, there are 3 stages of classification of binocular single vision. The first thing is simultaneous perception. What is simultaneous perception? Simultaneous, at the same time, perception, perceive. So are we seeing an image from both eyes at the same time? Okay, that's the first thing we have to think of. Is our patient sitting there and is an image being perceived, both eyes, or are they suppressing? Okay, so simultaneous perception is if a patient doesn't suppress. Okay, so sometimes you have simultaneous perception and you have normal binocular single vision. Like me, I'm looking here. I've got an image coming from my right eye. I've got an image coming from my left eye. I've got normal binocular single vision. What's abnormal binocular vision? So not single vision. So we have simultaneous perception, but the eyes are not facing in the same direction. So what can happen? Sometimes they're superimposed. We can have diplopia, so we can see double, or we can have confusion. So we see one image, if we have a really big squint, we can see one image that's very far away coming over here. So I'm looking at you straight ahead at me, and I can see my shelf over there in my line of vision here as well. So simultaneous perception, number 1, no suppression. Okay. Second thing is sensory fusion. So sensory fusion is when we see 2 similar images and we interpret them as one. So we've ticked off simultaneous perception. Okay, we've got the first stage. Number 2 is we're seeing 2 similar images and we're only interpreting it as one, as that third eye. What do we mean by 2 similar images? Well, everybody, just try this for a moment. Put your finger out in front of you, right in front of you. Look at your finger. Don't look at me. Don't look at the screen. Look at your finger now. Close one eye, close the other eye. Does it look like the finger's moving? Try it. I'll give you another second to try it. So close one eye, close the other eye, keep the finger in the same place. It looks like the finger's moving slightly. Okay, so we've got 2 similar images, but when we keep both eyes together and we look at the finger, it looks like we've got one finger. We've not got double vision there. That is sensory fusion. That's very normal. Okay. For this to happen, both images must be similar size, similar clarity, and similar brightness. Now, if we've got anisometropia, so we've got a refractive error in one eye and not the other eye, or we've got a smaller refractive error in one eye rather than the other one, they're not going to be similar, are they, the 2 images? So it's going to be very difficult. We're going to have this retinal rivalry going on. We won't be able to fuse the 2 images. So that's where it gets cut there. Okay. So the next step is motor fusion. What is motor fusion? So we're seeing an image from both eyes, we're fusing them together. And so motor fusion is the ability to keep them two images perceived as one when we change the versions. Okay, how do we do that? We usually do that with prisms. Okay, and why is it important? So in our assessment as an orthoptist, if we're thinking of a patient who's going to have squint surgery, we want to look at the patient's long-term stability of a successful surgical outcome, or we want to look at how well they're controlling if they have a latent phoria. Okay, so that's why we look at that. It's, you don't need to worry too much about the motor fusion, but it's something nice for us to do as orthoptists if we're looking at surgery and things. And the last thing, the last stage of binocular single vision is stereoscopic vision, 3D vision. So us looking in the world and noticing where things are in relation to another. It's the perception of depth. And I'm going to talk more about these things, and I'm going to talk more about 3D vision. Hopefully you guys will understand that if you're thinking of binocular single vision, I want you to go through these stages. Okay, have you got simultaneous perception? Tick. No double vision, two eyes working together. Have you got fusion? Tick. Okay, next thing, have you got stereopsis? Can you have stereopsis if you don't have simultaneous perception? So if you have suppression, can you have stereopsis? Can you have 3D vision? No, we're blocked at the first one. So I want you guys to keep thinking of this. Always remind yourself the 3 stages: 1, 2, 3. Simultaneous perception, fusion, 3D stereoscopic vision. Okay? Now, when I'm starting my assessment with the patient as an orthoptist, and you all do it as well, as a clinician, any type of a clinician, the most important to begin with is the history. Okay? Number 1, any previous ocular history? Any reason for a squint now? Any reason for, blurry vision? Anything? What is going on? Have you had any surgeries before? Have you had any eye drops? Are you using, patient might come and they're using dilating drops for something. What is it? We need to know that first. Any family history, this gives us a little nugget. This gives us a little inkling to what's going on as well. Birth history. So for littlies, we usually like to know about the birth history. Were they born prematurely? Was it a normal delivery? Was it a forceps delivery? These things can affect the nerves and the muscles. Was it traumatic? A birth weight? Were they a low birth weight or normal? Were they in NICU for a while? And the last thing, general health medications. Are they on any medications? How's their general health? Any associated syndromes? Any associated medical diseases? So that's the first thing. It gives you a lot, okay? And then, of course, their chief complaint. Why are you here today? What have you noticed? How long has it presented for? These are the most important things for us, okay? Now, if we look at a patient and we want to look at atropia, what is atropia? Okay, atropia is a deviation that's there all the time. It's a squint, it's a strabismus. These are other words for it, okay? In the UK, there's lots of other nicknames that they have for it. In over here in the region, Hawal sometimes, and Haraf they call it. It's a manifest deviation. It's there all the time. It can have a larger latent component, but we know that if you look at the patient, they've got a squint, okay? So if we go to this diagram over here, I'll just move this out of the way. These are normal eyes, okay? Nice and straight. This is one eye down. That's a hypotropia. One eye up, hypertropia. Exotropia is an eye turning outwards. esotropia is an eye turning inwards. Now, in all of these images that have the tropia, what do you notice? If you look at this eye, it's always in the middle, okay? So we don't have, although some patients might come in and say, both eyes are turning inwards, we don't have that. Unless they have a massive restriction, bilateral 6 nerve palsy, just say, and they can't physically turn their eyes out. Normally, they usually fix with one eye and the other eye is not in the center, okay? And you might initially notice that the squint, so just say this exotropia is a right exotropia. You might initially notice that they have a right exotropia, but when you start testing, it might move and then they end up with a left exotropia, sorry. That's very normal, okay? What you want to do, how do we test for this? We do a cover and a cover test. So we have an occluder, cover one eye and look at the eye here and uncover. So we keep looking at this eye and see, is there a movement? No movement. Okay, does that mean the patient's got no squint? No, it doesn't, because we need to test the other eye to see if there's a squint in this eye. So then we do cover and see if this eye moves, uncover, see if the eye moves, okay? So always, always, always start off with the history. Well, you're going to do the vision first, history, then cover test. Cover test is the first one. And remember, it's cover, uncover, cover, uncover. Okay, and we're looking at the other eye from the one we're covering. So we're looking to see if there's a movement and cover, movement and cover. Okay. Now, this long. So aphoria is a latent deviation. What does that mean? Well, it means we close our eyes and our eyes relax. And how do they relax? Very normally, the eyes relax a little bit outwards. And what we want to do is we want to open our eyes and we want to see how quickly do our eyes come back into normal? How quickly do our eyes come into straight? Okay. So majority of normal people will have a latent deviation. You'll have either an exophoria and esophoria. They're very normal, okay? How do we test that? We do an alternate cover test. So we do the cover over one eye, and then we switch over very quickly to the other eye. But we have to give time for this eye to fix, and then this way, and then this way. And the eye we have to give the patient time to fix on the target. So we normally do it at near, at around 33 centimeters with like a Snellen stick or a fixation stick. And then we usually do it in the distance, whatever your distance is, whether it's 3 meters or 6 meters, we find a target in the distance as well. And it's also important to test the control. So what does that mean? We do an alternate cover test. And then when we get to one eye, so we know, okay, Fahima's got an exophoria. We get here and then we move the cover away. And as we're moving the cover away, we're looking, is Fahima fixing in the center again? Or is Fahima's eye now turning outwards? Has she become manifest? Okay, because it's very, it is possible that a latent deviation can become manifest. We normally call them intermittent as well, intermittent squints. Okay, next thing we do normally as an orthoptist, ocular motility. So we test the patients in 9 positions of gaze. So we start off in primary position and we do a cover test. Okay, then it doesn't matter what sequence you go in. Absolutely doesn't matter as long as you do all the 9 positions of gaze. Personally, I like to do whichever one I do next, I like to do it with the opposite one. So if I go in levoversion, I like to go in dextro straight away. Why? Because I want to compare if there's a restriction on this side compared to this side, or if that's just how my eyes look. It's much easier to compare to know if there's restrictions or underactions or overactions. So you go in primary position, so direct elevation, direct depression, dextroversion, levoversion, dextro elevation, levo elevation, dextrodepression, and levo depression. And why do we need to go in these diagonal gazes? Because we want to look at the obliques. How are they doing? Okay, so if we look at this diagram over here, this diagram over here, we see up. So we're looking, when we're looking in up gaze, so we're looking at direct elevation, we're looking at the function of the superior recti. Okay, when we're going in down gaze, we're looking at the function of the inferior recti. Okay, when we're looking when we're looking in right gaze, we're looking at the lateral rectus of this eye, the medial rectus of this eye, and left gaze, lateral rectus of this eye, medial rectus of this eye. When we go up over here, just say we're looking at this superior oblique, okay, and this this inferior oblique. So one thing you have to remember is, although on the anatomy the superior oblique is over here, and on the anatomy the inferior oblique over here, the direction in this direction, so in the direction of the superior oblique, we're actually looking at the inferior oblique. And in this direction, the direction of the inferior oblique, we're actually looking at the action of the superior oblique. So that swaps over, okay? And it's important to know if the superior oblique, especially when we look down here, if it's restricted, or if we have a fourth nerve palsy, because the fourth cranial nerve is the one that supplies the superior obliques. We've got the third cranial nerve. Think back to what that supplies. So that supplies the levator, that supplies the superior rectus, that supplies the medial rectus, the inferior oblique, and the inferior rectus. Okay, and what does the sixth nerve supply? Think about it for a second before I tell you. The sixth nerve supplies the lateral rectus, both eyes. Okay. Now, test for retinal correspondence. How do you test retinal correspondence? So if we're going down now, the 3 stages classifications on BSV. So first, we're looking at, is there any simultaneous perception? Well, what do we do? Bagolini glasses. So you see these glasses over here? They have these little lines over here, lines over here. Okay, I'll talk about that in a second. We've got a red filter test as well. That's a nice test to do. And we've got the Worth 4-dot test. So this is telling us, has the patient got simultaneous perception? Have they got diplopia? Or are they suppressing? Okay, so Bagolini glasses we can do at near and distance. They have diagonal lines in opposite direction of either eye. So it'll have lines over here, lines over here. What we do is we ask the patient to hold the glasses in front of their eyes, and we shine a light in front of them. So if we're doing it at near 33 centimeters, we shine a light and we ask the patient, what do you see? Do you see my light? Yes. How many lights do you see? Do you see 1 or 2? I see 1, okay, I've got single vision. I see 2, okay, we've got double vision. Okay, from my light, you should have some lines coming out of the light, okay? How many lines do you see? Now, if this patient has normal retinal correspondence between the 2 eyes, then they will have X, okay? So it will look like an XY because the line's shining this way in one eye and the light's shining this way in the other eye. Okay, and it crosses in the middle like a cross. Okay, if they have abnormal retinal correspondence with binocular vision, then what we'll have is they'll have an X, but they'll have a little missing piece. To be honest, when I've tested patients who have abnormal retinal correspondence, none of them have ever reported that to me. So although we know it in the literature, I've never seen in the clinic anybody report that to me. Diplopia is the 2 lines, I've said that already. Now suppression, what do we notice in suppression? Well, if we're suppressing, we're not using one eye, so we won't be seeing one of the lines. So we only see one line in suppression, okay? And sometimes if I wanna check if the patient, especially if it's a child, if they're being honest, what I do is I quickly, whilst I'm shining the light, I cover one eye and say, what do you see now? Cover the other eye, see what do you see now? Because it would swap over the light. Okay, and then we've got tests for motor fusion. So how do we test motor fusion? So what was motor fusion again? Do you remember? Okay, so with motor fusion, what we're doing is we've got our normal sensory fusion. So we've got two similar images. Again, remember the finger, we've got two similar images, and we're perceiving it as one in normal, free space, normal, okay? With motor fusion, what we're going to do is we're going to move some prisms in front of the eyes, and we're going to move the image and see if the other eye can keep up. So for younger children, a very easy test is we just get a single loose prism, a 20 diopter base out prism, and we put it in front of one eye, and we see if the other eye, what should happen is this eye would shift and then come back into play, okay? And this eye under the prism goes inwards, okay? In adults, what we do is we have a prism bar. So you see these prism bars over here? So what we do is we build up. So we start off from the small prisms in front of one eye, okay, get them to fix on a target, and we tell them to tell us whether they see double or whether it gets really blurry. At the same time, we're looking for at their eyes as well to see if they're still moving, okay? And then finally, you can do this on a synoptophore as well. Do you all know a synoptophore? It's a very old device that orthoptists like. We always like to have one around, even if we don't use it often. It's always about in a clinic. We can't have a clinic without a synoptophore, and we do use it every so often. We do pull it out. We need to dust it out and clean it every so often to use it as well. Okay, now stereopsis. This is a fun one. This has got a lot more theory about it. What's stereopsis? So again, it's the perception of depth, okay? And the reason I say perception of depth is because of what we're going to come through. So any object that falls close to the horopter. So we've got the horopter, which is a line in free space, okay? So we're looking at an object, and we've got this line around the object, which we call the horopter. And then this space around it, so there's little dots around it, which we call Panem's fusional area, is where we can look around it and things don't seem double. What does that mean? So I just want you to kind of look to the side and look at an object, okay? It's very normal to have physiological diplopia. So just focus on something, look at something. So I'm looking at, there's a lamp over there. I'm looking at the lamp, and a lot of things around me are double. So just closer to me and further away, they're double. But there's things over here that are quite single, and that is Panem's fusional area, okay? So 3D vision is our depth perception, okay? So what we see, which is single, because of these, obviously we know that things are nearer or further away from us, okay? Because we also use something called monocular cues. What are monocular cues? Well, I'm telling you right now that you need two eyes to see 3D. Okay, so we look and we see the horopter and Panem's fusional area, and that's how we see 3D. But if you think about it, and if you close one eye, I still know that my laptop is in front of the wall behind it. How can I see 3D when one eye is closed? It doesn't make sense. I've just told you one thing and now I'm changing. That doesn't make sense. Well, it does, because we use cues. We use monocular cues. So we use size. Well, the wall behind is much bigger than the laptop in front of me. We look shading, lighting, overlap. So there's an overlap between the laptop and the wall, and there's a few bits behind as well. And then linear and aerial perspective. Now I want you, because now you're probably thinking, well, I'm not seeing much difference. I'm looking around and I can see where everything is. Try it. Close one eye, look around the room, and everything kind of, you know where everything is. You know where it is in relative to each other. So what do you need two eyes for? Why do you need two eyes for stereopsis? Well, okay, try this. Put one finger out in front of you again. Okay, easy one. Take the other finger, put it on top. It's good. Okay, now try that. Wait, wave your hands around. No cheating. Okay, now try that when one eye closed. So close one eye. Put the finger there. Now try it. Yeah, I missed mine. I know some clever clogs are going to have got it straight away, but you know, you get the point, you understand. Okay, so we've gone through the 3 stages again. Okay, we're on stereopsis. This is our last test. This is our last stage, sorry. How do we test for stereopsis? We have some tests for them. So TNO, have you guys seen a TNO? It's a book and you have red and green goggles and you have some pictures in there and you just ask the patient if they can see 3D. Okay, and you have some like dots and which one's 3D and things like that. It has a scorecard, very easy. Workfly, run dot, very similar. It's just a black 3D glasses and a book, and the fly, you usually ask them to like pick the wings. A frisbee test, not many people know this one, but this one is my favorite. So it's a box and you open it up and you have these glass plates and you can move. The reason I love it is, one, I can use it in children, really, really small children, and older kids and adults as well. And it is just 4 plates. So it has a plate, sorry, it has 4 boxes, and in one of them there's a 3D circle and they just point, and that's absolutely fine. And it's nice and easy. Lang is a card that has a few 3D pictures that we usually use on children. I personally don't like Lang. I feel like they kind of seem to look just around, and I can't pinpoint whether they're actually looking or not. With frisbee, it's very obvious if the child is non-verbal or especially shy, then I can tell where they're looking. And also I can adjust the distance as well to make it harder or easier. And then finally, that age-old machine, the synoptophore, we can use as well for stereopsis. Right, that's my 3 stages of classification of BSV done, and all the tests that you can use to test it. Any questions?
Thank you, Dr. Fahima, for sharing your valuable and insights and expertise with us. It was a very nice session. If you have any question, guys, please send them in the chat box so we can ask them to the doctor. As I would like to thank Mrs. Lara Abu Aid and Mrs. Christina Sauma, Mrs. Malak Awada, and the president of the Lebanese Sight Care Society, Mr. Joe Romanus, for their attendance. Thank you.
Okay, so I'm looking at the question. The first question, how can you control suppression when doing motor fusion testing? Remember what I said, you're going through the 3 stages. So if you've got suppression, that means you've not got simultaneous perception, which means you're not going to have motor fusion. So we're not going to test for that. Okay, so if we have a patient, they've got a squint, a large squint, they've got suppression or amblyopia, whatever it is, they've got suppression, then we're not going to do motor fusion on them. They're not going to have motor fusion. You need to have simultaneous perception before we can do the next level of tests.
We have another question. It's about oculomotor apraxia. Can you tell us more about that, please? Thank you.
Hello?
Yes, Fahima, go ahead, please.
Sorry,
Yes,
did I miss that? I missed that, sorry.
Yeah, I will repeat the question again. It's
Sure.
about oculomotor apraxia.
Oculomotor apraxia?
Yeah, can you
Yes.
speak?
So what about it?
Can you speak about it a little bit, about the movement of the eyes, how it goes on?
Okay, so oculomotor apraxia, I mean, is there anything specific you want to know about it, or just a general, you want me to tell you what it is?
No, in general, in general.
In general. Okay,
Yes.
so with oculomotor apraxia, it's when the patient can't fix for a long time. So normally our eyes, they have these saccades, we move, our eyes move a little and we can see things in real time. For some children, what we have is we find that they can't do that. So things get kind of stuck. Imagine you've got your realm around you and it gets stuck in that. And what do they have to do? They have to move their head to align and see what's going on in real time again. So every so often you'll notice like a tick. So sometimes we get children, we get patients, the parents come in and they say, oh, my child moves their head a bit differently and things like that. And then when we're doing the test, they see very well, but what you notice is every so often they have this little tick and they're doing this. And that's just to realign again.
So, Kausar, do you have any more questions or just that?
No, that's it. Thank you, doctor, for this session. It was very beautiful.
Thank you. I hope I made it easy for you guys. But if there is a part of it that wasn't, my whole aim was just so that you could, use it in practice and really like get it embedded and go back to the basics before you go right into the, more difficult things. And if anyone ever wants to reach out and has any questions, absolutely, I'm always happy to help. I'm very passionate about this.
Thank you. Thank you for your time.
Thank
It was
you.
a pleasure.
Thank you, everybody.
Thank you.